This is the activity video for Chapter 28, the reproductive system, in which we're going to go through and answer the questions from the in-class worksheet. So Part 1, Spermatogenesis versus Oogenesis. So number 1, fill in the chart below to compare and contrast spermatogenesis and oogenesis. So I'm going to go through this chart on the next couple of slides. So the site where it takes place. Spermatogenesis occurs in the testes, and more specifically in the seminiferous tubules of the testes. Oogenesis occurs in the ovaries, and it occurs in the cortical or outer region of the ovary. So when does the entire process start? For spermatogenesis, it starts at puberty. For oogenesis, it starts before birth. When does the entire process end? For spermatogenesis, it never ends. It continues throughout a male's lifetime. And for oogenesis, it will end at menopause. And then the name of the starting stem cell, in spermatogenesis, it is a spermatogonium. And in oogenesis, it is an oogonium. And so also keep in mind that before this process is started, the DNA in these cells is duplicated. And these are diploid cells which have 46 chromosomes, 2 pairs of each of the 23 chromosomes. So we're going to start with the stem cell. So we just named the stem cells at the end of the previous slide. So the type of cell division that the stem cell undergoes in spermatogenesis is mitosis, and in oogenesis it is also mitosis. So remember that mitosis produces 2 identical diploid daughter cells. And the reason that the stem cells undergo mitosis is that so one of the daughter cells can become a primary spermatocyte or oocyte, while the other one can remain a stem cell to allow production to continue. So it maintains the population of stem cells. So the time frame and location of the stem cell division. It occurs every day in spermatogenesis, and it takes place in the outermost layer of the seminiferous tubules, so the farthest away from the lumen or the space in the middle. In oogenesis, this takes place before birth, and it occurs in the primordial follicles. And the name of the cell that results from the stem cell division, in spermatogenesis, this would be your primary spermatocyte. So again, I start with the spermatogonium, which is the stem cell, and it's going to divide and produce 2 identical daughter cells. One is going to stay a stem cell so that we can keep making these cells in the future, and the other one is going to become the primary spermatocyte. And these are diploid cells that have 2 copies of each chromosome. In females, this would be the primary oocyte. So my oogonium, my stem cell, will undergo mitosis. It'll make another oogonium that'll keep my stem cell population full, and then it will also make a primary oocyte, which is also diploid and has 2 copies of each chromosome. So now we're going to carry on from where we just got our primary spermatocyte and primary oocyte. So the type of the next cell division is going to be meiosis 1. And meiosis 1. So both sides, spermatogenesis and oogenesis, are now going to head into meiosis. And recall that meiosis has 2 phases, so meiosis 1 and meiosis 2. And during the first phase, homologous chromosomes are separated. So the time frame and location of the next cell division, in males, this is going to be every day. And it's going to occur in the next layer inward of the seminiferous tubules. And in females, this process of meiosis 1 starts before birth in the primordial follicles, but then once a month between puberty and menopause, the process will complete in the tertiary follicles. And the name of the cell resulting from the next cell division is a secondary spermatocyte in males. So the primary spermatocyte undergoes meiosis 1 to make 2 secondary spermatocytes. and in females it'll be a secondary oocyte. So the primary oocyte will undergo meiosis I to make a secondary oocyte and a polar body. And then remember that this process pauses halfway through, so it's going to pause here where you see the arrow. The primary oocyte will pause during prophase 1, and it will stay that way until the tertiary follicle is stimulated during an ovarian cycle. So it'll pretty much stay paused from the time that a female is born up until a particular monthly cycle that particular tertiary follicle is activated. So carrying on with our secondary spermatocyte and secondary oocyte. So the type of the last cell division in males is going to be meiosis II, and in females is also going to be meiosis II. And again, recall that meiosis has 2 phases, and during the second phase, sister chromatids are separated. So the time frame and location of the last cell division. In males, this is again going to occur every day, and it will occur in the next layer inward. So we're getting closer and closer to the lumen of the seminiferous tubules. In females, this meiosis II will start once a month during the ovarian cycle in a tertiary follicle, but again it's going to pause, and it will only complete if fertilization occurs in the uterine tubes. So the name of the cell resulting from this last cell division, in males it would be a spermatid. So my 2 secondary spermatocytes that I previously made are each going to undergo meiosis II to give me 4 spermatids. And then in females, the final cell would be a mature ovum. So my secondary oocyte will undergo meiosis II to give me a mature ovum. But again, remember that it's going to pause halfway there. It's going to pause during metaphase 2, and it will stay in this pause state until it is fertilized. So it will not complete meiosis II unless it is fertilized. All right, so carrying on, we're starting with the spermatid and the mature ovum. Now the question is, do these cells need further processing? Explain. So in the case of males, yes, the spermatid does need additional processing. So in the process of spermiogenesis, the spermatid is going to be converted into a physically mature sperm. So I ended up with my 4 spermatids at the end of meiosis II, and then these spermatids will have to undergo spermiogenesis to make the cells that actually look like sperm. Spermiation is the process when the sperm break free to enter the lumen of the seminiferous tubules. And then the sperm still have to undergo functional maturation in the process called capacitation. So does my ovum need any additional processing? No. And then the last question on this slide, the path of the gamete release. So for the sperm, after they leave the testes, they're going to go through the epididymis, and then through the ductus deferens, and then into the ejaculatory duct, where they are mixed with secretions from the seminal glands, and then out through the urethra. In oogenesis, the ovum is going to go from the ovary to the uterine tube, and then to the uterus, but it will only implant in the uterus if it is fertilized by the time it gets there. Otherwise, it is going to disintegrate. Are all of the cell divisions equal? In spermatogenesis, the answer is yes. The end result of spermatogenesis is 4 equally sized spermatids. And then, as we explained previously, the spermatids will undergo spermiogenesis to make the physically mature sperm. In oogenesis, the answer is no. Meiotic divisions are unequal. One daughter cell gets most of the cytoplasm and organelles, while the other becomes a polar body that degenerates. So the end result of oogenesis is 1 ovum and then 2 to 3 polar bodies. So if this first polar body undergoes meiosis II, you'll have 3 polar bodies, but sometimes it may not undergo, and then you would only have 2 polar bodies. The name of the final gamete in spermatogenesis would be sperm. and oogenesis would be your ovum. The number of chromosomes in the gamete. In spermatogenesis, there will be 23 chromosomes in each sperm, so they are haploid, meaning they only have one copy of each chromosome. And the same is true for oogenesis. Each of the ovum is only going to have 23 chromosomes, so they will be haploid as well. And then the frequency of gamete readiness. In spermatogenesis, basically sperm are ready to be released every day, and males make 500 million sperm per day from puberty onwards. In oogenesis, only one secondary oocyte is released per month, and then only from the period between puberty and menopause. So part 2, we're going to look at some reproductive system case studies. In case number 1, we're going to take a look at endometriosis. So case number 1, a 26-year-old female complains of severe, dull, aching pain and cramping in the lower abdomen during her monthly menstrual period. Her monthly cycle is also frequently accompanied by intestinal cramping and diarrhea. A laparoscopy revealed the presence of ectopic endometrial tissue on the uterine wall, ovaries, and intestines. The patient was then diagnosed with endometriosis. So note that when you see the word ectopic, it means in an abnormal place or position. So most people are used to seeing this in reference to pregnancy. So like an ectopic pregnancy is a pregnancy that occurs other than inside the uterus, like if the pregnancy occurs in the uterine tube, for example. So ectopic endometrial tissue means endometrial tissue that is not inside the uterus in the endometrium where it is supposed to be. And so, in fact, with endometriosis, you actually have endometrial tissue that can grow outside of the uterus. So it can grow on the outside of the uterus, outside of the uterine tubes. It can grow in the ovaries. It can grow on ligaments. It can grow on the intestines and other places within the abdominal pelvic cavity. So number 1, review the structure and function of the uterus. Describe the 3 layers of the uterine wall. So the uterus is a pear-shaped hollow organ divided into 4 main regions. There is the large body, there's the fundus, which is the part that protrudes superiorly above where the uterine tubes attach. There is the narrow isthmus region, and then there is the cervix at the bottom. So the uterus is anchored in place by the broad ligament and other ligaments. And the most inferior part is called the cervix, and this projects downward into the superior portion of the vagina. So the function of the uterus is to provide mechanical protection, nutritional support, and waste removal for the developing embryo and fetus. So now let's look at the 3 layers of the uterine wall. So the outermost layer is called the perimetrium. And so this is going to be continuous with the peritoneal lining. So it would be the same thing as the visceral peritoneum on the uterus. Then you have the myometrium, which is a muscular inner layer. It has 3 layers of smooth muscle tissue, longitudinal, circular, and oblique orientations. And the myometrium makes up 90% of the uterine mass. And then you have the endometrium, which is a highly vascularized inner layer that has secretory glands. And it is divided into a functional layer and a basal layer. And the functional layer changes with the monthly uterine cycle, while the basal layer remains fairly constant. Number 2, review the uterine cycle. Describe the 3 stages of the uterine cycle. Make sure to mention the role of the sex hormones in these 3 stages. So the uterine cycle lasts 28 days, and it is tightly linked to the ovarian cycle, and it consists of 3 phases. So the first stage is called the menstrual phase, or menstruation, or menses. And this phase is triggered by the sudden drop in estrogen and progesterone levels. And in this particular picture I'm showing you down here, they're just mentioning estradiol, and estradiol is one of the main estrogens. So when you have very low hormone levels of both estradiol and progesterone, that's going to trigger the menstrual flow phase of the uterine cycle. So during this phase, the functional layer of the endometrium deteriorates after arteries constrict and cut off blood supply to this layer. Weakened arteries are then going to rupture, and the blood and degenerating tissue is shed through the vagina. This can last between 1 and 7 days, and usually between 35 and 50 milliliters of blood is lost. The next stage is the proliferative phase, and this phase is stimulated and sustained by the presence of estrogen. So as estrogen levels go up because of changes that are taking place in the ovarian cycle, that is going to trigger the endometrium to grow and to replenish itself. So the proliferative phase is characterized by the regrowth and restoration of the functional layer of the endometrium. By the end of this phase, the new functional layer of the endometrium will be several millimeters thick. And then we have the secretory phase, which is going to be the last 14 days. And this phase is stimulated and sustained by the presence of progesterone and estrogen, specifically estradiol. So during this phase, this correlates with the luteal phase of the ovarian cycle. So you have rising levels of progesterone. You still have estrogens around, although not as high as you had during the proliferative phase, but your high progesterone combined with the lower levels of estrogen promote the secretory phase. And during this phase, the uterine glands are enlarged and are secreting a glycogen-rich mucus. And this stage will persist for as long as the corpus luteum in the ovary remains intact. But if pregnancy does not occur, then this phase typically only lasts about 14 days. And then because of the corpus luteum degenerating in the ovary, the estrogen and progesterone levels will fall off remarkably, and then that will trigger the next menstrual phase. Number 3, to better understand the fluctuating sex hormones in a woman's body, review the ovarian cycle. Differentiate between the 4 continuous preparatory phases and the 3 phases that occur each month as part of the hormone-driven cycle. Which structures within the ovary produce which hormones? So there is a constant development of early stage follicles in the ovary. And so we're going to look at this top picture for this. So up here where it says constant development of early stage follicles. So this is going to start with primordial follicles, which are surrounded by a single layer of granulosa cells, also called follicle cells. So primordial follicles will mature into primary follicles, and during this process, the granulosa cells are enlarging and forming the zona pellucida, which is a zone of interaction between the granulosa cells and the oocyte. And then the primary follicles are going to enlarge into secondary follicles. At this stage, you'll start to see thecal cells surrounding the outside of the follicle. And then secondary follicles will enlarge into tertiary follicles. And at this stage, you start to get follicular fluid accumulating to form the antrum. So at each of these stages, many of the follicles degenerate in a process called atresia, which leaves fewer follicles to advance to the next stage. So up here in this top picture we were looking at initially, you can see how as you go along, some of these say atresia. That means that they basically degenerate, so that by the end, only like one of these 3 primordial follicles has actually become a tertiary follicle. And then here is another image for you showing the progression from primordial follicle to primary follicle to secondary into early tertiary. And note that these early stages are independent of the amount of hormones that are present. It's not until we get to the tertiary stage that hormones are going to start having an effect. And then this particular picture down here is showing how at each stage you can lose some of these follicles to the process of atresia. So once we have our tertiary follicles, this is when these follicles start becoming susceptible to the hormones that cycle monthly. So the monthly ovarian cycle is divided into 2 main phases. First, we have the follicular phase, which is the first 14 days of the cycle. And during this phase, you have follicle-stimulating hormone causing the tertiary follicles to accelerate their development. And then by day 5, there is a single dominant tertiary follicle, shown here. It continues to grow and develop. And around day 14, a surge in luteinizing hormone is going to cause ovulation to occur, in which the tertiary follicle ruptures and ejects the oocyte. Then you move into the luteal phase, which is the second 14 days of the cycle. And then under the influence of the luteinizing hormone, the remaining granulosa cells that were left behind from the ruptured follicle form a structure called the corpus luteum. And then about 12 days after ovulation, if fertilization has not occurred, the corpus luteum degenerates into the corpus albicans, which is essentially a little mass of scar tissue. So the hormones that are produced by the ovary, so the granulosa and thecal cells produce estrogen, and this is responsible for this increase in estrogen that you have over the first 14 days, which is what is taking your uterus from menstruation when the levels were low to the proliferative phase when the estrogen levels were high. And then the corpus luteum produces large amounts of progesterone and smaller amounts of estrogen. So because the corpus luteum forms in the luteal phase, this is where you're going to have your progesterone high secretion, and that's going to drive the secretory phase of the uterine cycle. And then I included this comic here because I couldn't stop laughing at the little luteinizing hormone guy slapping the tertiary follicle to make it spit out the oocyte during ovulation. But maybe this little comic can help you do some reviewing. The only difference between this comic and the charts we've looked at previously is that they've divided the menstrual phase of the uterine cycle kind of from the right to the left. So you have to remember that you kind of wrap around from here to here. But it's talking about how you've got low estrogen that is happening during the menses phase. And then during the ovarian cycle, the follicular phase, you've got the development of the follicles, which are releasing estrogen. And that's when you're going to have the proliferative phase in the uterus. And then your little luteinizing hormone is going to come around and smack your tertiary follicle and make it spit out the oocyte, which is ovulation. And then the tertiary follicle that's left is going to turn into the corpus luteum, which is going to produce progesterone. And when you have progesterone, your uterine lining is going to change into the secretory phase where it's making all of this rich, glycogen-rich mucus. And then if your oocyte is not fertilized, this corpus luteum will degenerate into the corpus albicans. And then because you have a drop-off in hormone levels, that's going to trigger the next menses. Number 4, propose a possible mechanism for how endometrial tissue can get into the abdominopelvic cavity. So if you recall, the fimbriae at the end of the uterine tube does not directly attach to the ovary. It looks like fingers that drape over the ovary, but it doesn't actually attach to the ovary. There is a space there. So typically, the cilia lining the uterine tube will create a current in the fluid that encourages the released oocyte that is released during ovulation to enter the uterine tube. However, because the end of the uterine tube is essentially open to the abdominal pelvic cavity, it is possible for some of the menstrual fluid during menstruation to flow up the uterine tube and out of the end of the uterine tube and into the abdominal pelvic cavity. This process is called retrograde menstruation, because instead of going downward and out the vagina like it should, it is going back up through the uterine tube and out the end into the abdominal pelvic cavity. So once this endometrial tissue enters the abdominal pelvic cavity, it can implant in various places. So it can implant on the outside of the uterus, on the ovaries, to the intestines, and even to the peritoneal membrane lining the cavity. And so all of this endometrial tissue that is no longer inside the uterus is what causes endometriosis. And it's unknown why this happens in some women and not others. Some of the hypotheses include having a small cervical opening, which means it's not as easy for the blood to exit, so it's easier for the blood to back up and go out the uterine tube. Having strong myometrial muscle contractions, so if you have extra strong contractions of the myometrium, that could force blood up and back out the uterine tube. And then genetics also seems to play a role. In rare cases, a fertilized oocyte can also implant in the abdominal pelvic cavity instead of the uterus, again because these two structures are not connected. And if this happens, this results in a very dangerous, life-threatening abdominal pregnancy where the developing embryo starts growing in the abdominal pelvic cavity, and it will still form a placenta, but the placenta can attach to anything in the abdominal pelvic cavity like the intestines or the mesenteries or even the peritoneal lining. So it is not only endometrial tissue that can get out this way. So number 5, how would this ectopic endometrial tissue change as hormone levels in the body change, and how could this cause problems? So even though it's no longer inside the uterus, the endometrial tissue still responds to the changing hormone levels that occur throughout the monthly cycle. So after menstruation is over, the rising estrogen levels will cause that tissue to grow and thicken until it is several millimeters thick. This is the proliferative phase, and it doesn't matter that it is no longer inside the uterus, it's still going to undergo these changes. So after ovulation, the rise in progesterone levels will cause all of this endometrial tissue to secrete glycogen-rich fluids, which is the secretory phase. And then once progesterone and estrogen levels fall with the degeneration of the corpus luteum, the ectopic tissue will degenerate and bleed, just like the endometrium that is still inside the uterus. So since this is happening inside the abdominal pelvic cavity, and there is nowhere for the degenerating tissue and blood to go, it can cause local inflammation, cysts, and pain. And then over time, these areas can also develop into adhesions that also contain scar tissue from the repeated bouts of inflammation. So this is essentially the same lining of your uterus, but it's going through all of these changes in your abdominal pelvic cavity instead of inside the uterus. So if endometrial tissue attaches to the intestines, either the large or the small, it can also cause intestinal irritation, which can lead to intestinal cramping and diarrhea during the menstrual phase. So places in which ectopic endometrial tissue has been found include the uterine tubes, both inside or outside, ligaments around the uterus, the lining of the pelvic cavity, the ovaries, the outside of the uterus, in spaces around the uterus, the bladder, both intestines, the rectum, the abdominal lining, even in the vagina or the vulva. Number 6, brainstorm possible ways to treat this condition. So pain medication is given to control the pain symptoms, but there are actually only 2 real ways to treat endometriosis, either hormones or surgery. So hormonal treatments include things like progesterone, which will lock the tissue into the secretory phase and prevent the menstrual phase from occurring. Contraceptives, which eliminate the monthly cycling of the hormones. Androgenic steroids, which inhibit endometrial growth altogether, but because these are androgens, they can also cause unwanted side effects like the growth of facial hair. Gonadotropin-releasing hormone agonists, which can cause downregulation of hormone receptors and a decrease in FSH and LH. Aromatase inhibitors, which will block the formation of the estrogens. And remember, estrogens promote endometrium growth, so blocking the formation of estrogens will prohibit the growth of the endometrium. Surgical treatments include laparoscopic procedures to remove the endometrial tissue, which is called excision, or to use heat to destroy it, which is called ablation. However, it has the potential to reoccur in the future. So you can undergo the surgery to have it removed, but that doesn't mean it's not going to regrow later on. A hysterectomy, which is the removal of the uterus, can also be done with or without also removing the ovaries, which is called an oophorectomy. So a hysterectomy can prevent the future implantation of new endometrial tissue, but it's only really effective if the surgeons remove already existing ectopic endometrial tissue at the same time. Removal of the ovaries will stop all of the hormones that cause the endometrial tissue to change, but then it will also cause menopause. So here's a little fact sheet about endometriosis. It actually is very common. It affects more than 1 in 10 women. Experts actually believe the number might be significantly higher, but people tend not to report it or it's misdiagnosed. So common symptoms are painful periods, severe pelvic cramping, heavy bleeding, infertility, pain during sex, painful ovulation, urination and bowel pain, constant fatigue, bleeding and pain between periods, digestive problems, periods lasting longer than 7 days, and ovarian cysts. And so this is one of the largest women's health crises of our time. Usually females go 8 to 10 years before they get an actual diagnosis. They have a 2 to 3 times higher risk if a close relative has it. They can tend to lose a lot of work hours, which causes economic loss. It also has a fairly high infertility rate. There are different stages, but pain does not always correlate with the severity of the disease. So even someone with stage 1 can have very severe debilitating pain. There's also a lot of society stigma. Women are forced into a culture of science about their bodies and menstrual cycles, and many doctors are misinformed, and a lot of people just don't want to talk about women's health, and then a lot of people don't even know about it because of inefficient sex education. And one big myth surrounding endometriosis is that having a child will cure it. So I actually had endometriosis, and I actually had a hysterectomy when I was only 29 years old. And my parents used to tell me, oh, just have a kid, that'll cure it. But that is not a cure for endometriosis. So part 2, we're still moving on with the case studies. This is case number 2, an enlarged prostate gland. So case number 2, a 55-year-old man is the owner of an adventure tour company and is looking forward to an exciting year full of amazing trips. The patient had previously had very few health problems, but now notices that he is increasingly having problems passing his urine. It appears that the harder he tries, the slower the urine flow becomes. The doctor ordered a CT that showed an enlarged prostate gland with partial obstruction of the prostatic urethra. The PSA test showed low levels of PSA. So here's what an enlarged prostate gland would look like. And so it can cut off the flow of urine because the prostatic urethra passes right through the middle of the prostate gland. So number 7, what is this patient's diagnosis? What evidence led you to this conclusion? So this patient is suffering from benign prostatic hyperplasia, or BPH, also called benign prostatic hypertrophy. So this is what it looks like. It would be an increased or enlarged prostate that can close off the prostatic urethra and block the flow of urine. So the clues in this case is that the man had an enlarged prostate, but he had low PSA levels. So prostate-specific antigen, or PSA levels, are used to determine if the cause is prostate cancer. With prostate cancers, PSA levels increase, and with BPH, they stay low. BPH is very common in men older than 50, and the exact cause is poorly understood, but it is thought to be related to decreasing testosterone levels and rising estrogen levels. Treatments can include surgery or medications to either reduce certain hormones or to increase relaxation of smooth muscle in the urethra. And here's an example of one of the types of surgeries where they actually go in there and they implant a device that holds the prostate gland open, which allows urine to flow through the prostatic urethra with no issues. Number 8, the prostate gland is an accessory gland in the male reproductive tract, what is its function, and what are some of the other accessory glands found in the male tract and their functions. So the prostate gland functions to produce a fluid called prostatic fluid, which contributes about 30% to the volume of semen. So remember, semen is a mix of sperm and fluids. Prostatic fluid is slightly acidic. Prostatic fluid contains seminal plasmin, which acts as an antibiotic to prevent urinary tract infections in males. It also contains enzymes that assist with both the clotting of the semen and the dissolving of the semen clot, called fibrinolysis, that occurs 15 to 20 minutes after the clot forms. The other accessory glands are the seminal glands, also called the seminal vesicles. These produce a seminal fluid which contributes 60% to the volume of semen. The fluid produced by these glands is alkaline in order to neutralize acids in the male urethra and the female vagina. The fluid contains a high level of fructose, which acts as an energy source for sperm. The fluid contains prostaglandins to promote peristalsis in both the male and female tracts. And the fluid contains fibrinogen, which can be converted to fibrin to allow the semen to clot and form a temporary semen plug in the vagina. And then we have the bulbourethral glands, also known as Cowper's glands. These produce small amounts of mucus, which contribute up to 5% to the volume of semen, and which help to lubricate the gland's penis. Secretions are a thick alkaline mucus that can help neutralize urinary acids in the male urethra. The final part of the fluid component of semen comes from the nurse cells in the testes and secretions by the epididymis. Number 9, where is the prostate gland located in males? So the prostate gland sits just inferior to the bladder in males. So this is the bladder and the prostate gland is underneath it. And then here is another view where again you can see the bladder and the prostate gland underneath it. And then here is a mid-sagittal view, so you can see the prostatic urethra as well as the ejaculatory duct that runs through the prostate, coming down from where the ductus deferens joins up with secretions from the seminal vesicle. So part 2, case number 3, erectile dysfunction. So a 75-year-old man shows up to his doctor's office accompanied by his wife for his 3-month diabetes evaluation. He continues to smoke despite multiple attempts to stop and strong advisement by all of his medical providers. He is also currently overweight at 252 pounds. During the visit, the physician notices tension between the patient and his wife. When the doctor inquires, both the patient and his wife break into tears and say that they are experiencing personal problems at home. Upon further questioning, the physician finds out that the patient has not been able to achieve an erection for the last 20 months, despite a previously healthy sex life and continuing to find his wife attractive. The physician assures the couple that many men experience erectile dysfunction. The doctor first checks the patient's testosterone levels, and finding them normal, suggests again that the patient should quit smoking and lose weight. He also prescribes sildenafil, which is the brand name Viagra, to the patient, although he takes the time to emphasize the continued importance of lifestyle interventions. During the next visit, the couple are noticeably happier, and the man has lost 25 pounds and has cut back on his smoking. So number 10, describe the structure of erectile tissue. It's the same structure in men and women, and where it is found in men and women. How does erectile tissue become erect? So erectile tissue consists of a three-dimensional maze of vascular channels partitioned off by smooth muscle fibers. In the resting state, the arterial branches that feed these areas are constricted and blood flow into this tissue is limited. So males and females have two main types of erectile tissue, which are color-coded in this particular picture here, with the clitoris on the left and the penis on the right. So first we have the corpus cavernosum, which is shown by this teal green area. So males have 2 columns of corpus cavernosum on the anterior side of the penis. Females have 2 columns that are joined together and which extend back from the clitoral glands. So note that the crus, which is colored in yellow in both of these pictures, is an extension of the corpus cavernosum, so it is also erectile, and it's given a different name because it's the part of the system that anchors the genitals into place. Then we have the corpus spongiosum, which is colored in these 2 images in purple. And males have a single column on the posterior side of the penis, and this is the portion where the spongy urethra passes through. So it's called the spongy urethra because it's passing through the corpus spongiosum. And females have 2 columns that extend around and wrap around the 2 sides of the vagina, and these are also called bulbs of vestibule. Both sexes also have some expanded corpus spongiosum that makes up the glands, which is shown in pink in this image. So for the second part of the question, how does erectile tissue become erect? So during an erection, the parasympathetic nervous system causes the release of nitric oxide. Nitric oxide increases the production of cyclic GMP, which promotes smooth muscle relaxation. So this is a pathway inside of the cell similar to what we looked at earlier in the semester when we looked at how the photoreceptors work in the retina. And so we're not going into all of the details, just that nitric oxide activates an enzyme that creates cyclic GMP, and cyclic GMP then follows a pathway that ultimately leads to smooth muscle relaxation and erection. So smooth muscle relaxation around the arteries feeding the erectile tissue causes blood to move into the maze of vascular channels, which engorges the area with blood and results in an erection. And then also important to this particular case study, note that there is an enzyme called phosphodiesterase, or PDE, which we also have seen earlier in the semester. And this enzyme breaks down cyclic GMP, which would also ultimately stop the erection by stopping the smooth muscle relaxation. So number 11, how do erectile dysfunction drugs like Viagra, which is sildenafil, work? And what kinds of side effects could such a drug cause? So the most common types of erectile dysfunction drugs like Viagra work by increasing the ability of nitric oxide to cause smooth muscle relaxation, which leads to vasodilation of the arterioles, which increases blood flow to an area. And of course, when we're talking about an erection, we are increasing blood flow to the erectile tissue. So these drugs do this by blocking the enzyme that breaks down cyclic GMP, which is that enzyme called phosphodiesterase. And without phosphodiesterase able to work, all of the increased cyclic GMP levels caused by the nitric oxide stick around longer, which result in a longer, more stable erection. So here's the pathway that we looked at earlier. So these drugs are working by blocking this enzyme, which is necessary for turning off the erection. And so once you have nitric oxide released, you're going to get smooth muscle relaxation and a continued or extended erection. So sexual stimulation and arousal are still required to get the parasympathetic neurons to release the nitric oxide in the first place. But once the nitric oxide is released, Viagra will allow the erection to be maintained. So Viagra is not going to give you an erection if you're not already sexually stimulated or aroused, but when you are sexually stimulated or aroused, it will allow you to maintain an erection. So note that there are other drugs on the market that target other components of this pathway. I'm just focusing on the actions of Viagra because it is the most common and most well-known erectile dysfunction drug. So nitric oxide, this is going to answer the second part of the question about side effects. Nitric oxide causes vasodilation, but it doesn't just target the arteries leading to erectile tissue. Nitroglycerin, for example, is given to treat angina because it converts to nitric oxide and causes vasodilation of coronary arteries. But again, it's not targeting those coronary arteries. So the bottom line is that nitric oxide and nitroglycerin, they cause vasodilation in all of the arterioles. So any drug that causes vasodilation will cause widespread vasodilation, which could lower blood pressure, which is called hypotension, and it can also increase the risk of clots, which could lead to heart attacks or strokes, because if you reduce the blood pressure, then the blood is not moving as quickly and it can sit there and it can clot. So side effects of erectile dysfunction drugs include hypotension, increased risk for heart attack or stroke, or even priapism, which is a prolonged erection that lasts for 4 hours or longer, which is why if you've ever seen those drug commercials, they always say, you know, go see a doctor if your erection lasts for longer than 4 hours, when they're spilling all the side effects at the end. Number 12, why did the doctor check the testosterone levels? What are the functions of testosterone? And how do the functions of testosterone compare to the functions of estrogen? So the doctor would have checked for testosterone levels because of testosterone's functions. One of the functions is to maintain a normal sex drive or libido in males. So the doctor wanted to make sure that this patient's issue wasn't related to his sex drive. Now we're going to compare the functions of testosterone to the functions of estrogens side by side, so that you can see how similar they are, and then that can help you remember them together instead of trying to remember them as 10 separate items. So testosterone maintains the sex drive or libido in males. Estrogens maintain the sex drive or libido in women. And again, remember, testosterone is a type of androgen, and estradiol is the main type of estrogen. Testosterone stimulates muscle and bone growth. Estrogens stimulate muscle and bone growth. Testosterone establishes and maintains male secondary sex characteristics. Estrogen establishes and maintains female secondary sex characteristics. Testosterone maintains accessory glands and organs of the reproductive system. Estrogen maintains accessory glands and organs of the reproductive system. So far, if you remember one list, you've essentially memorized the other list. So there's only one big difference between these two sex hormones, and that is that testosterone allows nerve cells to be stimulated by follicle-stimulating hormone, and nerve cells are only going to be found in testes, so they're only going to be found in males. And estrogens initiate the repair and regrowth of the endometrium. The endometrium is the inner lining of the uterus, so this would only be a function applicable to females. And then you can see that the chemical structures of these two sex hormones are also extremely similar. There are only mild differences between them. And in this final part, part 3, we're going to look at gender identity and the Lady of Charleston and talk about sexual development. So this case is based on the real-life story of Dawn Langley Simmons, who published her autobiography in 1995 called Dawn, a Charleston Legend. Dawn Simmons was born as Gordon Langley Hall in England in 1937. Mrs. Simmons claimed that she was born with an adrenal abnormality that caused the female genitals to appear male at birth. Consequently, she was raised as a boy. After moving to America and settling in Charleston, South Carolina, she underwent a sex change operation, and then a year later, she married John Paul Simmons in 1968, who was an African-American sculptor and mechanic. This was actually the first legal interracial marriage in South Carolina and reportedly caused more trouble for Mrs. Simmons than the fact that she lived 30 years of her life as a man. The story gets even more interesting as Mrs. Simmons alleges to have become pregnant and gave birth to a child in 1972, although some researchers dispute the validity of this claim and say that it was actually one of her relatives that gave birth to the child. So here is a picture of Gordon Langley Hall, and then here is a picture of Dawn Langley Simmons on her wedding day. And then here is a picture of her with the baby and her husband with their baby. So number 1, how is sex determined in humans? What role does the SRY gene play, and what role does testosterone and Mullerian inhibiting factor play? So usually sex is determined by the inheritance of the sex chromosomes. Females usually result from receiving two X chromosomes, so an XX genotype, and males usually result from receiving one X and one Y chromosome, so an XY genotype. But there are several steps in the actual development of the gonads, the internal reproductive structures, and the external genitalia. The first step depends on whether or not there is an SRY gene present, and this gene is normally found on the Y chromosome, and SRY stands for sex-determining region of the Y chromosome. If an SRY gene is present and functional, the immature gonads develop into testes. If the gonads develop into testes, they can then release testosterone and Mullerian inhibiting factor, or MIF. The presence or absence of testosterone and Mullerian inhibiting factor affects the fate of two embryological structures called the Wolffian duct and the Mullerian duct. The presence or absence of testosterone also changes the development of the structures that become the external genitalia. So in general, testosterone and Mullerian inhibiting factor lead to the development of the male structures. Otherwise, the female structures develop by default. So I went over this in the lecture, but I'm going to go over it again as a review. So in the embryo, we have the indifferent gonads. We also have the Wolffian duct, the Mullerian duct, and then the embryological structures called the genital tubercle, the urethral fold, and the genital swelling. So up to 7 weeks of embryological development, these structures are identical in males and females. So if there is an SRY gene present, so like for example, if they have a Y chromosome with a functional gene, the gonads will develop into testes. Then the testes will produce testosterone and Mullerian inhibiting factor. In the presence of testosterone, the Wolffian duct will develop into the ductus deferens, the prostate gland, the epididymis, the seminal vesicles, and all of the internal structures. In the presence of Mullerian inhibiting factor, the Mullerian duct will degenerate. And in the presence of testosterone, these external structures will develop into the penis, spongy urethra, and scrotum, which are the external male genitalia. So in the absence of the SRY gene, the gonads will develop into the ovaries. Once they become ovaries, they do not produce testosterone, nor do they produce Mullerian inhibiting factor. So in the absence of testosterone, the Wolffian duct degenerates. In the absence of the Mullerian inhibiting factor, the Mullerian duct becomes the uterus, uterine tubes, and upper vagina. And in the absence of testosterone, these external embryological structures become the clitoris, labia minora, and labia majora, or the female external genitalia. So number 2, what other structures in the body produce androgens? So the adrenal cortex, and specifically the zona reticularis, also produces androgens. So quick review to earlier this semester, we have the adrenal gland that sits on top of the kidney. The medulla makes the catecholamines, which is epinephrine and norepinephrine. Then the next layer out, which is the zona reticularis, that makes the androgens. The middle cortical layer, which is the zona fasciculata, makes your glucocorticoids like cortisol. And then the outermost layer of the cortex, called the zona glomerulosa, makes your mineralocorticoids like aldosterone. So both males and females have adrenal glands. In males, the levels of androgens produced by the testes normally dwarf the production of the androgens made by the adrenal glands. But in females, the adrenal gland is the primary source of androgens. Number 3, is it sufficient to just have a hormone present in your body for that hormone to function normally? What else must you have? So as it was stressed repeatedly during the endocrine system chapter at the beginning of the semester, A hormone can only exert its influence on a cell if that cell has receptors for that hormone. So we looked at how if we have two different example hormones here, hormone A and hormone B, if we have a cell that has receptors for hormone A, then only hormone A is going to affect that cell. A cell that only has receptors for hormone B is only going to be affected by hormone B. And then if a cell is going to be influenced by both hormones, it has to have receptors for both types of hormones. So if a cell does not have a receptor for a particular hormone, or that receptor is broken, like say due to a genetic mutation, then the cell cannot respond to the hormone signal. And since sex development involves the presence or absence of multiple hormones, it is dependent on cells having the correct receptors and that those receptors are functioning and working normally. So number 4, what are some ways that the sex development process might not follow the normal pathway? Explain. So we're going to take a look at 3 examples and see what would happen to the pathway in these cases. So we're going to look at what happens when an XX individual has a mutation that causes excessive androgen production by the adrenal glands, and this is called congenital adrenal hyperplasia. We're going to look at an XY individual that has a mutation in the SRY gene that renders it non-functional. And we'll look at an XY individual that has a mutation in the androgen receptors, which is called androgen insensitivity. So keep in mind that intersex is the term that we use to describe what occurs when the external genitalia do not match the internal sex organs or the genetic sex. And up to 1.7% of babies are born with sex characteristics that don't fit typical definitions of male and female. That makes being intersex as common as being a redhead. And intersex people can be any gender. And so I like the statement down here, let's become a world that gives self-determination to children born with intersex natural bodily variations. So now let's look at our first scenario. So what would happen if we have an XX individual that has a mutation that causes excessive androgen production by the adrenal glands? All right, so we're XX, which means we don't have an SRY gene because we don't have a Y chromosome. So the gonads will develop into ovaries. And the ovaries typically do not make any testosterone, and they make no Mullerian inhibiting factor. But in this particular case, the adrenal glands are making excess testosterone, which is the primary androgen, during the developmental period. So with the presence of this testosterone, the Wolffian duct will develop into the ductus deferens, the prostate gland, the epididymis, and other internal structures. I still don't have any Mullerian inhibiting factor because Mullerian inhibiting factor is made by the testes, and I don't have any testes. So since I don't have any Mullerian inhibiting factor, the Mullerian duct will also develop into the uterus, uterine tubes, and the upper vagina. However, again, I do have testosterone, so my genital outer structures will develop into the penis, the spongy urethra, and the scrotum. So I would have an XX individual with ovaries and a uterus who also has a penis, a scrotum, a ductus deferens, a prostate gland, and an epididymis. Now the scrotum would be empty because there are no testes, but the skin would still be there. Now let's look at an XY individual who has a mutation in the SRY gene that renders it non-functional. So normally, if I have an SRY gene on the Y chromosome, my gonads will develop into testes. But in this case, the SRY gene is mutated and doesn't work, so it's as if it does not exist. So without the SRY gene, the gonads will then develop into the ovaries. The ovaries are not going to produce testosterone or Mullerian inhibiting factor. So without testosterone, the Wolffian duct will degenerate. Without the Mullerian inhibiting factor, the Mullerian duct will become the uterus, uterine tubes, and vagina. And without the testosterone, the external embryological structures will become the clitoris, labia minora, and labia majora. So you can have an XY individual who has ovaries and all of the female parts. Now let's look at what would happen if you have an XY individual who has a mutation in the androgen receptors, which is called androgen insensitivity. So because it's an XY individual, I would have an SRY gene on my Y chromosome. That would cause the gonads to develop into testes. I have testes, so they're going to produce testosterone and Mullerian inhibiting factor. But because of this mutation, the cells can't respond to the testosterone signal. Remember, a hormone can only work if the cells have functioning receptors. So because cells can't respond to testosterone, it's as if it does not exist. So because the testosterone essentially doesn't exist because the receptors aren't working, the Wolffian duct is going to degenerate. Now I still have Mullerian inhibiting factor, so Mullerian inhibiting factor is going to cause the Mullerian duct to also degenerate. But again, even though I'm producing testosterone, the cells can't sense it, so it's as if I don't have testosterone, so the external embryological structures will develop into the female external genitalia. So you can have an XY individual with internal testes, these testes won't drop because there's no scrotum, and a external female genitalia. So hopefully this helps you to be a little bit more tolerant and to better understand intersex. So again, intersex is used to describe individuals whose chromosomes, hormones, or sexual organs are not in line with the perceived male-female sex binary. And then when a baby is born, sex is usually determined by a doctor based on the size that they see. So if they look at the genitals and they see a protrusion that is 1 inch or more, they say it's a boy. If it's small, oh, it must be a clitoris, so it's a girl. And if it's anywhere in this range here, so babies with ambiguous genitals often undergo inhumane, dangerous, and unnecessary surgeries to normalize their genitals, many times without parental consent, as I discussed in my lecture video. So intersex people are about as common as redheads. They can have any sexual orientation or gender identity. They should never be called hermaphrodites. They should have their privacy respected. They should not have to be ashamed of their bodies, and they deserve to be treated like anybody else. And here is an example of how you can end up in this gray range here. So we've already looked at the structure of the clitoris versus the penis. And so because they both develop from the same developmental structure, you can get structures that end up being kind of halfway between the two extremes. So you could have a baby born with a very large clitoris, for example, and you can even have a baby born with an sort of an undersized penis that even has the urethra coming out of the bottom rather than at the tip. So there are a whole range of different types of genital anatomies that you can see, and they are all normal. And so we shouldn't stigmatize people who are just born with things that we're not used to talking about or seeing. So the last question, number 5, what role does the brain play in the development of a gender identity? So exposure to sex hormones during a critical period of development plays a role in the patterning of the brain for male and female characteristic behaviors. These can be hormones produced by the embryo fetus itself or to which they are exposed while in utero. There is also no one set of all male or all female behaviors. The chemical changes within the brain follow a continuum of behaviors. The brain has widespread hormone receptors, and new studies suggest that estrogen and testosterone themselves may even function as neurotransmitters in some brain areas. Females even show differences in working memory, emotional memory, and the stress response depending at what point they are in their ovarian cycle. And this shows that sex hormones can continue to affect the brain function even in adulthood. And to give you an example, estrogen is associated with better memory than progesterone. And since women have high levels of progesterone during pregnancy, remember progesterone, progestation is the pregnancy hormone. This is why we talk about a pregnancy brain when women have a period of higher than normal levels of brain fog where they have difficulty remembering things, and that is because of the difference in hormones. So the bottom line is that how a person perceives their own gender, so their gender identity, and the types of people they are sexually attracted to, the sexual orientation, has a lot to do with brain patterning and is not a conscious choice. So to quote Lady Gaga, I was born this way. And that is the end of the Chapter 28 activity video.